Welcome, Dr.Tay Kiang Hiong from Singapore, sharing about effectiveness of combination cutting balloon and drug-coated balloon angioplasty of AVF patency.
Good morning, everyone. Apologies for not being able to be personally present in Taipei to deliver this talk. I would like to congratulate the organizers for going forward with this meeting and using technology to enable the conference to go on. This morning, I would like to talk on using a combination of cutting balloon and drug-coated balloon for angioplasty of dialysis AVF stenosis. These are my disclosures. Of note is that the two trials that I'm going to talk about, the institution and concerto trials, were both partially funded by Boston Scientific. All of you are probably familiar with the KDOQI guidelines. Up to today, POBA is still the gold standard for the treatment of AVF stenosis. As you can see in these pictures, the results are often good, but the 6-month primary patency is often less than 50%. Fortunately, with repeated intervention, we are able to maintain the patency and function of this fistula, and 12-month secondary patency in excess of 80% is quite easily achievable. The main pathologic basis for development of stenosis is the neointimal hyperplasia. Numerous strategies have been described to address this entity, and here is one such example in an animal study where drug-eluting stent and bare metal stents were compared with the drug-eluting stent successfully inhibiting the neointimal response. Of course, in recent years, drug-coated balloon angioplasty is the new favored method, and numerous randomized trials have already proven its efficacy when compared to POBA. Way back in 2014, we have done a randomized clinical trial comparing cutting versus high-pressure balloon for the treatment of resistant AVF stenosis. In this trial, we found that the 6-month primary patency of cutting balloon is superior to high-pressure balloon, and the difference is statistically significant, and the effect size is about 25%. 4 years later, our group conducted another randomized trial, this time comparing POBA with drug-eluting balloon. And again, we show that the drug-eluting balloon is superior to POBA at both the 6-month and 12-month time point. And they were statistically significant differences. The effect size is about 20%. So DCB is 20% superior to POBA. So we hypothesized that if we combine cutting balloon and drug-coated balloon, we may be able to get better patency. And the reason being, with a cutting balloon, we could reduce elastic recoil by disrupting the fibrotic stenosis. And as we know, recoil is a determinant of patency. Also, in cutting balloon, the disruption of the stenosis is controlled. Hence, it should incite less intimal response. And further, the cuts made by the blades of the cutting balloon potentially could improve drug delivery to the various layers of the vessel wall. So we went on to conduct 2 trials, the institution trial and the concerto trial. So the acronym is generated using a software, and this is what it stands for. Essentially, the difference between the 2 trials is that for institutional trial, we are looking at recurrent stenosis, whereas in the concerto trial, we are looking at stenosis that were resistant to conventional angioplasty. We will show you the details in the later slides. So in institution trial, as I mentioned, we use a combination of cutting balloon and drug-eluting balloon for recurrent stenosis, and recurrent is defined as within 1 year of the last intervention. This is a prospective single-arm observational study, and I'll be presenting the interim analysis. We have already completed patient recruitment, a total of 44 patients, and 28 patients have already completed 12-month follow-up, and I'll be showing the data of these 28 patients. The primary and secondary outcomes are the standard ones that we see with fistula intervention. In the interest of time, I will be focusing only on primary patency of the target lesion. Of note, the patency assessment is based on clinical follow-up and not on imaging. The fistula is about 4 years old on average. The radiocephalic AVF forms the majority of the fistula, and most patients had interventions about 6 months before the index angioplasty. Target lesion length about 5 cm. Most of the lesion, as expected, is in the juxta anastomotic segment. The pre-treatment stenosis is severe, more than 70%, and most cases have a single lesion, but we do have some cases with more than one lesion, and in these cases, the most severe lesion will be chosen as the target lesion. The cutting balloons used are from 5 to 7 mm, and the drug-eluting balloons usually are oversized by 1 mm more. Most have good results with less than 30% residual stenosis, but we do have 8 patients with more than 30% residual due to elastic recoil. The target lesion patency is about 85% at 6 months and 66% at 12 months. This is one example, very typical juxta anastomotic stenosis, treated with cutting balloon first, followed by the drug-coated balloon, and this is the result. This patient has not come back for repeat intervention, and it's already more than 12 months. This is another patient where the result is not as good. As you can see, the lesion is very long. Although the post cutting balloon and post drug-coated balloon angioplasty looks good, the patient returned about 7 months later due to decreased flow rates, and the repeat intervention angiogram shows restenosis of the treated segment. Next, we talk about the Concerto trial. As mentioned earlier, this trial is similar to the institution trial, but it involves resistant AVF stenosis. Again, it's a single-arm observational study. The sample size calculation was based on a 20% effect size, giving us 19 patients. So all these patients first underwent angioplasty with POBA up to 15 atmosphere inflation pressure, and they will only go on to the combination cutting balloon and drug-eluting balloon angioplasty if there is more than 30% residual stenosis. Similar set of outcomes as its institution trial, except that the cut-off time point is 6 months, and again, patency assessment is based on clinical follow-up. Fairly similar to institution trial, about 4 years old, AVF age, predominantly radiocephalic fistula. Almost 80% have prior angioplasty. Lesion length is a bit shorter for this trial. The lesions are a bit more evenly distributed, and we have a bit more patients with more than one lesion, and again, only the most severe lesion is chosen for the trial. This is one example from the trial of severe stenosis of BBT, AVF. After POVA, significant recoil, and went on to have cutting balloon followed by drug-coated balloon with good results. So for this trial, the residual stenosis is again quite good, and technical success was 18 out of 19. One patient had greater than 30% residual stenosis. And at the end of 6 months, none of the patients lost so-called target lesion patency. Only one patient returned for repeat intervention, and it was due to non-target lesion stenosis. So in essence, the 6-month primary target patency was 100% for this trial. So if we compare these two trials with our two earlier trials, we could see that it seems to show that by combining cutting balloon and drug-coated balloon, we have better results than cutting balloon alone or drug-coated balloon alone. Obviously, strictly speaking, we can't really compare the trials like that, but suffice to say that it is not worse than either. So to really be very sure, we need head-to-head trials by comparing cutting balloon or drug-coated balloon with the combination treatment. So in conclusion, our preliminary observations suggest that the combination of cutting balloon and drug-coated balloon is safe. We did not see any complication in both our trials. It is at least as effective as a cutting balloon or drug-coated balloon angioplasty alone. But our data seems to suggest it's better, and we feel that further studies are warranted, in particular randomized control trials, to confirm its efficacy and value in the treatment of AVF stenosis.